Lewis's Medical Surgical Nursing, 11th edition, Chapter 36, Selected Reading Assignment, pages 794 to 800. Cardiomyopathy. Cardiomyopathy is a group of diseases that directly affect myocardial structure or function. CMP is classified as primary or secondary. Primary CMP refers to those conditions in which the heart is idiopathic. The heart muscle is the only part of the heart involved, and other heart structures are unaffected. In secondary CMP, the cause of the myocardial disease is known and is due to another disease process. Three major types of CMP are dilated, hypertrophic, and restrictive. Each type has its own pathogenesis, clinical presentation, and treatment protocols. CMP that leads to cardiomegaly and HF is the main reason for heart transplants. Takotsubo cardiomyopathy is a transient heart syndrome that mimics acute coronary syndrome. Patients often have chest pain, ST segment elevation on the ECG, and elevated cardiac biomarkers consistent with an MI. However, when the patient undergoes heart catheterization, there is no significant coronary artery disease. It is an acute stress-related syndrome that is more common in postmenopausal women. Most patients recover rapidly without lasting symptoms. Dilated cardiomyopathy. Etiology and pathophysiology. Dilated cardiomyopathy is the most common type of CMP, with a prevalence of 5 to 8 cases per 100,000 people in the United States. It causes HF in 25 to 40% of cases and occurs more often in middle-aged blacks and men. Dilated CMP often follows an infectious myocarditis. Some evidence links dilated CMP with an autoimmune process or genetic causes. Alcohol-related dilated CMP has its own unique presentation and treatment. Other common causes of dilated CMP are listed in Table 36.14. Dilated CMP appears with diffuse inflammation and rapid degeneration of heart fibers. This results in ventricular dilation, impaired systolic function, atrial enlargement, and blood stasis in the left ventricle. SCD from dysrhythmias is a leading cause of death in idiopathic dilated CMP. Ventricular dilation causes cardiomegaly and contractile dysfunction. In contrast to HF, the walls of the ventricles do not hypertrophy. Clinical manifestations. The signs and symptoms of dilated CMP may develop acutely after an infection or slowly over time. Most people eventually develop HF. Symptoms can include decreased exercise capacity, fatigue, dyspnea at rest, paroxysmal nocturnal dyspnea, and orthopnea. As the disease progresses, the patient may have a dry cough, palpitations, abdominal bloating, nausea, vomiting, and anorexia. Signs can include an abnormal S3 and or S4, dysrhythmias, heart murmurs, pulmonary crackles, edema, weak peripheral pulses, pallor, hepatomegaly, and JVD. Decreased blood flow through an enlarged heart promotes stasis and blood clot formation and may lead to systemic embolization. Diagnostic studies. The diagnosis of dilated CMP is based on the patient's history and exclusion of other causes of HF. Doppler echocardiography is usually the basis for diagnosing dilated CMP. Echocardiography can assess EF. EF less than 20% is associated with a 50% mortality rate within 1 year. The chest X-ray may show cardiomegaly with signs of pulmonary venous hypertension and pleural effusion. The ECG may show tachycardia, bradycardia, and dysrhythmias with conduction problems. Laboratory studies may show increased B-type natriuretic peptide (BNP) levels if HF is present. Heart catheterization confirms or rules out coronary artery disease. An endomyocardial biopsy done at the time of the right-sided heart catheterization will identify any infectious organisms or other causes of disease. Interprofessional and nursing care. Interventions focus on controlling HF by enhancing heart contractility and decreasing preload and afterload. This is similar to the management of chronic HF. Treatment guidelines are based on a specific stage of disease progression. Treatment of patients with Class 4, Stage D, HF is more palliative than curative. Several different types of drugs are available to manage HF. Nitrates, e.g. nitroglycerin, and diuretics, e.g. furosemide, decrease preload. ACE inhibitors reduce afterload. Beta blockers, e.g. metoprolol, low pressor, and aldosterone antagonists, e.g. spironolactone, aldactone, control the neurohormonal stimulation that occurs in HF. Dysrhythmias are treated with the appropriate antidysrhythmic. Anticoagulation therapy reduces the risk for systemic embolization from clots that form in the heart chambers. Drug and nutritional therapy and cardiac rehabilitation may help 1. Lessen symptoms of HF, and 2. Improve CO and quality of life. Patient with secondary dilated CMP is treated for the underlying disease process. For example, teach the patient with alcohol-related dilated CMP to abstain from alcohol. Unfortunately, dilated CMP does not respond well to therapy, and patients have multiple episodes of HF. Patients may be hospitalized for infusions of dobutamine or milrinone, followed by aggressive diuresis. Sometimes these treatments are done in an outpatient setting or in the home under nursing supervision. After treatment, many patients see an improvement in symptoms for several weeks. Medical management is based on clinical guidelines for HF. Statins may be helpful. Patients may benefit from non-drug therapies. A VAD allows the heart to rest and recover from acute HF. May also serve as a bridge to a heart transplant. Other options include cardiac resynchronization therapy and an implantable cardioverter defibrillator (ICD). The patient with terminal or end-stage CMP may consider a heart transplant. A permanent implantable VAD, known as destination therapy, is an option for patients with advanced disease who are not candidates for a heart transplant. Currently, about 50% of heart transplants are done to treat CMP. Heart transplant recipients have a good prognosis. However, donor hearts are hard to obtain, and many patients with dilated CMP die before receiving a heart. Patients with dilated CMP are very ill and have a grave prognosis. Your expert nursing care is critical. Observe for signs and symptoms of worsening HF, dysrhythmias, embolus formation, and drug effectiveness. The goals of therapy are to keep the patient at an optimal level of functioning and out of the hospital. Always include caregivers when planning a patient's care. Encourage caregivers to learn CPR. Teach them when and how to access emergency care. Home health and hospice nursing can provide the patient and caregiver with palliative care. This includes strategies to maximize and maintain functional status or end-of-life care to prepare for a peaceful death. Hypertrophic cardiomyopathy, etiology and pathophysiology. Hypertrophic cardiomyopathy is asymmetric left ventricular hypertrophy without ventricular dilation. In one form of the disease, the septum between the two ventricles becomes enlarged and blocks the blood flow from the left ventricle. We call this hypertrophic obstructive cardiomyopathy, HOCMP, or asymmetric septal hypertrophy, ASH. Hypertrophic CMP occurs less often than dilated CMP. It is more common in men than in women. It is usually diagnosed in young adults and most often in active athletic persons. Hypertrophic CMP is the most common cause of SCD in otherwise healthy young people. It accounts for 3% of deaths in young competitive athletes. There's a link between genetic mutations and HOCMP. MYH7 and MYBPC3 are the two most common genes involved. They are found in about 50% of cases. of HOCMP. Early identification is important. The four main characteristics of hypertrophic CMP are 1. Massive ventricular hypertrophy, 2. Rapid, forceful contraction of the left ventricle, 3. Impaired relaxation diastole, and 4. Obstruction to aortic outflow, not present in all patients. Ventricular hypertrophy is associated with a thickened intraventricular septum and ventricular wall. The result is poor filling of the stiff ventricle. Decreased ventricular filling and obstruction to outflow can result in decreased CO, especially during exertion. Clinical manifestations. Patients with hypertrophic CMP may be asymptomatic or may have exertional dyspnea, fatigue, angina, and syncope. The most common symptom is dyspnea caused by an elevated left ventricular diastolic pressure. Fatigue occurs because of the resulting decrease in CO and in exercise-induced flow obstruction. Angina can occur and is often caused by the increased left ventricular mass or compression of the small coronary arteries by the hypertrophic ventricular myocardium. The patient may have syncope from obstruction to aortic outflow during increased activity. This results in decreased CO and cerebrovascular circulation. Syncope also can be caused by dysrhythmias such as supraventricular tachycardia, atrial fibrillation, ventricular tachycardia, and ventricular fibrillation. Diagnostic studies. Clinical findings on examination may be unremarkable. On a chest palpation, the apical impulse can be exaggerated and displaced to the left. Auscultation may reveal an S4 and a systolic murmur between the apex and sternal border at the fourth intercostal space. ECG findings usually show ventricular hypertrophy, ST to T wave abnormalities, prominent Q waves in the inferior or precordial leads, and dysrhythmias. The echocardiogram is the main diagnostic tool used to confirm hypertrophic CMP. It may show wall motion abnormalities and diastolic dysfunction. Heart catheterization and nuclear stress testing may help diagnose and guide the treatment of hypertrophic CMP. Interprofessional and nursing care. Goals of care are to improve ventricular filling by reducing ventricular contractility and relieving left ventricular outflow obstruction. These can be achieved with beta blocker, e.g. metoprolol, or calcium channel blocker, e.g. verapamil therapy. Digitalis is considered if needed to treat atrial fibrillation. Amiodarone or sotalol, beta pace, are effective antidysrhythmic drugs. However, their use does not prevent SCD. Patients at risk for SCD need a cardioverter defibrillator. AV pacing is helpful for patients with hypertrophic CMP and outflow obstruction. When the ventricles are paced from the apex of the right ventricle, septal depolarization occurs first. This allows the septum to move away from the left ventricular wall and reduces the degree of obstruction of the outflow tract. Some patients with severe symptoms unresponsive to therapy may be candidates for surgical treatment of their hypertrophied septum. A ventriculomyotomy and myectomy involves cutting into the thickened septal muscle and removing some of the ventricular muscle. Most patients have an improvement in symptoms and exercise tolerance after surgery. An alternative non-surgical procedure to reduce symptoms and the left ventricular outflow obstruction is alcohol-induced percutaneous transluminal septal myocardial ablation, PTSMA. This procedure consists of injecting alcohol into the first septal artery branching off the left anterior descending artery to cause ischemia and septal wall infarction. Ablation of the septal wall decreases the obstruction to flow, and the patient's symptoms decrease. The procedure can improve HF symptoms and exercise capacity. Potential complications of PTSMA include conduction problems, e.g. heart block, and MI. Nursing interventions for hypertrophic CMP focus on relieving symptoms, observing for and preventing complications, and providing emotional support. Focus your teaching on helping patients plan to avoid strenuous activity and dehydration. Any activity that causes an increase in systemic vascular resistance, thus increasing the obstruction to forward flow, is dangerous. Rest and elevation of the feet to improve venous return to the heart can help manage chest pain. Vasodilators such as nitroglycerin may worsen the chest pain by decreasing venous return and further increasing obstruction of blood flow from the heart. Restrictive cardiomyopathy, etiology and pathophysiology. Restrictive cardiomyopathy is the least common type of CMP. It is a disease of the myocardium that impairs diastolic filling and stretch. Systolic function stays unchanged. Although the specific cause of restrictive CMP is unknown, several pathologic processes may be involved in its development. Myocardial fibrosis, hypertrophy, and infiltration produce stiffness of the ventricular wall with loss of ventricular compliance. Secondary causes of restrictive CMP include amyloidosis, endocardial fibrosis, sarcoidosis, and radiation of the thorax. With restrictive CMP, the ventricles are resistant to filling and demand high diastolic filling pressures to maintain CO. Clinical manifestations and diagnostic studies. Clinical manifestations of restrictive CMP are fatigue, exercise intolerance, and dyspnea. These occur because the heart cannot increase CO by increasing the HR without further compromising ventricular filling. Other symptoms may include angina, orthopnea, syncope, and palpitations. The patient may have signs of HF, including dyspnea, peripheral edema, weight gain, ascites, hepatomegaly, and JVD. The chest X-ray may be normal or it may show cardiomegaly from atrial enlargement. Pleural effusions and pulmonary congestion may occur as the patient progresses to HF. The ECG may show mild tachycardia at rest. The most common dysrhythmias are supraventricular atrial fibrillation or AV block. Echocardiography may show a left ventricle that is normal size with a thickened wall, slightly dilated right ventricle, dilated atria. Endomyocardial biopsy, CT scan, and nuclear imaging may help the diagnosis. Interprofessional and nursing care. There's no specific treatment for restrictive CMP. Interventions are aimed at improving diastolic filling and the underlying disease process. Treatment includes conventional therapy for HF and dysrhythmias. Heart transplant may be an option. Nursing care is similar to the care of a patient with HF. As in the treatment of patients with hypertrophic CMP, teach the patient to avoid situations that impair ventricular filling and increase systemic vascular resistance, such as strenuous activity and dehydration. Nursing care of a patient with CMP includes individualized teaching based on the patient's manifestations. All patients with CMP are at risk for IE from any procedure that may cause bacteremia. Teach the patient about the need for prophylactic antibiotics.